Thank you very much. Good afternoon. My name is Peter Molyneux. I chair the board of Sussex Partnership NHS Foundation Trust. And you're welcome to this board meeting in public this afternoon. In terms of apologies for absence, I have apologies from Simon Blake, Dinesh Bugra, and Dr. Jessica Eccles. In terms of declarations of interest, are there any new declarations that haven't previously been declared? There aren't. Just to inform the board that I have let the company secretary know that as of Sunday, I ceased to be the interim chair of Camden Islington NHS Foundation Trust and Barnet Enfield and Haringey Mental Health Trust and the University College London Health Alliance. But that's now been recorded on the register and is on the public website. In terms of the minutes of the Board of Directors held on the 4th of October, can I please take the minutes for accuracy first? It appears like as I can, those are approved. In terms of the action log, I was happy that we're up to date with the action log. Our board members are also happy that we're up to date. It appears that we are. We don't have any questions today from members of the public. You will have seen circulated the chair's report, and what you will note is that many of the external meetings that I've been involved in over the last 2 months have been very much with different parts of the system. So people like Fiona Walsh at the Department of Health and Social Care, Ian Trenholm at the Care Quality Commission, Claire Murdoch, in terms of where we are in the NHS. And I think that will come through the afternoon in terms of the agenda that we have in front of us. So unless anyone has any questions for me, I will move to the Chief Executive's report. Jane.
Thank you, Peter. The report sets out quite a few national areas of work that are impacting on us and we're involved in, and I don't intend to go through all of those in detail, but happy to answer any questions, any queries that you have. But I thought I'd draw out a couple of key matters from the national bits. One is industrial action. You'll know from everything in the media that the consultants have reached an agreement. The SAS doctors have voted in favour of further strike action, and yesterday junior doctors announced that from 7 a.m. on the 20th of December until 7 a.m. on the 23rd of December and 7 on the 3rd of January to the 9th of January, they will be taking strike action. Obviously, that was only announced yesterday, but already the system is coming around that to think about how we manage these really busy times, particularly in the urgent and emergency care pathway. The other thing I wanted to highlight is CQC published their annual assessment of health and social care, and I've done a bit of a summary there, but I think it's disappointing that mental health is a key area of concern, but it does reflect the challenges we're facing, both nationally and internally: use of dormitories, safety concerns, recruitment and retention, as well as high use of bank and agency. And I think it's important to note that since the previous board, our CPC reporting to Chalk Hill has been published. And I want to be clear that what CPC found at Chalk Hill was not acceptable, and that although we were aware of challenges on our improvement on the unit, our improvement plan was in place, but wasn't moving at the pace in which it should have done. And we've reflected on that both as an executive team and as a board, and taken learning so that we learn from what happened, but also we've taken immediate actions in terms of Chalk Hill itself, and it is now reopened to admissions and is definitely on that improvement journey. The other thing that's mentioned in the CPC report, the annual report, is neurodiversity. And I think quite rightly, it's also been a focus in the system as well. An area of focus for the Mental Health, Learning Disability and Autism Board, who received a report about all-age neurodevelopmental programme. We also, you will know from the media coverage, we had the inquest into the death of Jessie, a woman who was on playground ward, and that highlighted concerns nationally about services for people with autism. I also attended a meeting that was hosted by the ICB with the local MPs, and it was about children and adolescent services, but every question was about neurodiversity and waiting times, treatment. So you can see it's all sort of coalescing around neurodevelopmental and neurodiversity. And I think we've got a lot of work to do in meeting the needs of the local population, but it does mean working differently, and it means working with partners across social care, education, other partners within health, the voluntary sector. It's certainly not something we can do alone, but also we need to be mindful of the work that's happening nationally in this area. The other thing I wanted to point out is that as our academic partners and our academic colleagues are looking at new models of care with neurodiversity in mind, they're being at the forefront of thinking differently about new models of care for this group of people. On the 8th of November, NHS England wrote to all trusts setting out the requirement to reach financial balance by the 31st of March next year, whilst protecting patient safety and prioritising emergency care. This required us to reduce from a 10.9 million deficit that we have predicted. The paper says 19 million because that was our underlying deficit prior to work we already had in place. So we were at 19 million. We were already putting in place plans to reduce the deficit, and we got it to 10.9 million. The primary driver of our deficit is our use of agency, and we are amongst the highest mental health trust in the country for the use of agency. This year we've seen some successes in reducing our use, but we need to build on that further. But we can't simply stop using agency. We can't simply just say no more agency, because that's going to impact on patient safety, which NHS England are very clear we shouldn't be doing, and we need to protect the UEC pathway. So therefore, we've been working through how we redeploy substantive staff, ensuring we protect our urgent and emergency care pathway and minimise risk. Winter planning has been taking place in the system, and part of our plan is the immunisation of staff. The update from the report is that we're 37% for COVID and 40% for frontline staff, and for all staff we're 38% for COVID and 40% for flu. So we're on target, but we've still got a long way to go, is how I frame that. I think it is important, not only in terms of making sure we are able to staff our services over the winter, but it is also important in terms of us protecting our vulnerable patients and vulnerable staff with protective characteristics who are vulnerable to flu and COVID. The UEC pathway is under significant pressure. We've seen a reduction in those needing admission because of the work being done by our crisis teams and our ATSs, but people are waiting too long for a mental health bed, and we continue to see a challenge with our medically ready for discharge. So if we look at this morning, we've had 112 people medically ready for discharge and 56 people waiting for a bed. We have contracted 11 additional beds with the independent sector within Sussex, and they're due to come online incrementally from this week. That will have some impact, but will not solve the problem. So we're looking at the full pathway, and the ICB is hosting a quality summit with health and social care partners next week to think about what the art of the possible is in doing something radically different to meet the increasing demand and the challenges across all partners. Our guaranteed employment offer for registered mental health nurse students has gone live. Myself, Teresa and Finley went to meet on the student nurses on their 5th day of training over at the University of Brighton, and told all of them that should they pass and register as a mental health nurse at the end of their training, they're guaranteed a job with us at the end of it, and their training is about finding their right place in SPFT so that they can have a fulfilling career. That was met really positively, and we've had a lot of feedback from students that they feel valued by the trust with the seniority of the people that came and the offer being given. What we now need to do is make sure that their placements are exceptional, so they want to stay with us at the end of their training. I want to end by mentioning our Positive Practice Awards. I'm sure those of you who are able to attend will agree that the comms team did an outstanding job organising the event. Thank you to them. It was moving to hear the exceptional work of our teams, both the frontline teams and support teams. But all, it was moving to hear how what they do impacts on the population that we serve in Hampshire and Sussex. But I'm also mindful that there are many people there that continue to do exceptional work. That is a mere drop in the ocean of the exceptional work that's done by the Trust. And it was really an honour to be with those that won awards that next year. And I look forward to reading the nominations for next year's events. I'm happy to take any questions.
Okay, thank you, Jane. And I think it's important that the board notes that the CQC report on Chalk Hill, and that the board will be doing a significant piece of reflective practice in terms of all the different elements of that, in terms of making sure we respond thoroughly both to the letter and the spirit of that report. Are there any questions for Jane? Peter?
Chair, thank you. I feel it's important, given that Jane has raised the issue of junior doctors' strikes in her report, just to reflect on the fact that as a trust, in common with the Queen Victoria Hospital, as we are largely a consultant-led medical workforce, the risk to our patients is considerably less than the risk in the acute hospitals, where they are predominantly a junior doctor or doctors in training-led workforce. What will happen, of course, is the system will focus rightly on the urgent and emergency care needs of people presenting, particularly in emergency departments, and therefore we will make a commitment and a contribution to keeping our current excellent level of service to the emergency departments, and we will be in a position to support our crisis teams and the outflow pathways therefrom. That's not to say that there won't be considerable pressure on us from our acute partners to do even better than we're attempting to do at the moment, and the board will be aware that the majority of our difficulties actually relate to the point that Jane made about medically ready for discharge and the difficulty our partners in our outflow pathways have in responding to that need. So this will be a complex situation, but there will be no risk from the medical workforce specifically within SPFT.
Thank you. I think that's important to hear, and we all have to hope that a resolution is found to this before we get to the dates that have been set out. But thank you for that reassurance. Anna.
Thank you, Chair. I just got two questions, Jane. Fantastic report, and really helpful to have that kind of, broad view, and then coming down to the kind of the delivery of services. The first question is just on the collaboration between local authorities and learning disability services, and those joint guiding principles that you talk about on page 4. I'm just interested to know, and maybe it's just to foreground this, whether or not that's been a co-produced exercise, whether people with learning disabilities, their families and clinicians have been involved in that, as well as obviously on the local authority side, because it feels to me like a really important lever in terms of integration and moving forward, and if co-production's in there, just to signal that it is. That's my first question.
If I answer that one first, Anna, if that's all right. So yes is the answer. So I know the national team the National Learning Disability team have people with lived experience within their team and contribute to things regularly. And I know lived experience is a really important part of their work. They also spoke to the NHS Conferred Learning Disability and Autism Board that I chair, and we have linked with a charity that works with people, so we get lived experience for us. I think the next stage is how we implement it locally and ensure lived experience is part of that, and that's the next stage. So the guidance has come out having used lived experience, but I think the implementation is the next bit for us, and it's important. I absolutely agree that we have co-production of how we implement it.
Thank you. That's very helpful and very illuminating. Can I ask one other question, Peter, if I may?
Mm-hmm.
But it's on the agency spend. So, you know, it's a downward trajectory, isn't it, now? But I suppose my question really is, you know, it talks about a national target of 3.7%. I just want to know how other trusts are getting anywhere near that, or whether there are examples from, you know, other countries, other jurisdictions that we can draw on, because this is not just our problem, is it? And you know, finding solutions and innovations elsewhere. I'm sure you've done that, but I'm just, and maybe that's too long a question, flagging it.
No, I think I've got something to say on it, so that's good. So there are two bits really. One is other areas do have this problem, but we are an outlier. I wouldn't want to pretend that we're like everybody else. We have more agency work than anybody else. We're one of the highest users in the country, so we have to be clear we do have a different problem to other people. We are part of the South East temporary workforce collaboration work, and that's led by Julian Ems, who is in Berkshire Health, and we are learning, and they've gone internationally and nationally and looked at best practice, and they're implementing that, so we're fully engaged in that process. You're right, we have made positive steps in the right direction. At the moment, we have made our use of agency has reduced by £400,000 a month for nursing. At the same time, that's slightly offset by our use of agency in the medical workforce, which is where our next target will be. So we have a net improvement of 200,000 at the moment per month. So we are making progress, but we have a significant way to go. And we are an outlier. So I think we need to do more than most in this area.
Okay, thank you. Jo.
Yeah, thank you. Just two questions, Jane, and also a point for Dan in relation to the second question. But on the first point, just building on Anna's point about co-production and involvement and engagement in co-design and co-production with our service users. I'm really pleased to hear that was done in relation to the LD and autism. But what I also want to encourage us to do is to find a path into bringing in other people who we wouldn't normally. I wouldn't be the usual suspects. It's what I think is the shorthand for what I need to say, because I think the more we can do on that front, the better. And then the other question or point was in relation to the Positive Practice Awards. My apologies, because I gave apologies a long time ago saying that I couldn't make the date. And you and I have spoken about the fact that there was very limited NED involvement. I'm sorry, my voice is tired today. Very little NED attendance. And I just wondered, when we come to the next round of preparing for this, thinking about how NEDs are engaged as well. So that I think if we were involved or wanted to be involved in looking at some of the nominations, and also actually looking at the dates before they're set, because I think I was reflecting on what the feedback that you gave some of us on this, and I think that actually, certainly my previous experience at SPFT was that it didn't feel like something that we were necessarily required to attend. It was a nice to do, and I think actually.
Sorry, I'm going to contradict you there,
Yeah.
because actually we did actually actively engage the non-execs in the quality awards originally. This year, the date was set without consultation with any of the non-execs, and I think that's partly where the problem came.
Okay, thank you.
Sorry, I just thought it was important just to
Sure,
that.
no, that's fine. I didn't realise the date was set without consultation.
I'll start with the latter point. So we're starting the planning for next year's Positive Practice Awards, and we will engage with all of you so that we have something written. Everyone is engaged in, and we really celebrate the work of the trust. In relation to your first point, I absolutely agree, and I think that's where our integrated community teams will come in. So we're going to have 16 integrated community teams across Sussex, East Sussex, Brighton and Hove and West Sussex, and they will. And the idea is that the services are very linked into their local communities, and they also look at making sure they reach their local population. And that's where I think we will do that meaningful work rather than at a trust-wide level of engaging people who wouldn't usually engage.
All right. Okay, Jane, thank you very much. So, I mean, I think that we note, I think it was good to have that conversation about the junior doctors' proposed industrial action and the fact that we will do our best as an organisation to maintain our contribution to the wider system. I think in terms of the Positive Practice Awards, obviously we reinforce the point you've made about the work that was done to organise those. And clearly there's a bit of learning in terms of making sure that we're engaging the widest group of people to be engaged in that possible. I think in terms of agency spend, it is important that we notice where we are benchmarking, that we're seeking to learn. We obviously welcome the reduction in relation to nursing, and we note the continued work to try and reduce agency spend within the medical workforce. I think that we received reassurance around co-production as we implement the learning disability and autism work at a local level. I think that may be something we want to bring back to the board, or to certainly highlight through the performance report at some point, at an appropriate point when we can do that. I go back to the point around the CQC report on Chalk Hill and the determination of the board to do reflective practice and to try and make sure that we absolutely learn the lessons from that in the round, and that we can then apply that both to Chalk Hill, but also obviously to all our reviews of services. So thank you for that, Jane. I'm going to move us on, and with the board's permission and with some trepidation, I'm going to ask the Chief Finance Officer to do two items together. So firstly, to do the financial position, and then to do the integrated performance report, and then to do the strategic review into the breakthrough objective. I think that might just flow a bit better. So Usman.
Thank you, Chair. I will say that I think Jane and the Chief Exec's report has covered off an element of what I was going to cover off in the finance, which I think shows sort of just the alignment between all of our sort of areas. But if I just I'll take the report I read, but I'll talk through some high level position. And then I think it's important just to sort of focus a little bit more on the actions and what we'll need to do to get back to break even. So at an overall level, at month 7, we had an actual deficit of 7.4 million, but it was sort of £4 million off plan. We had planned to have a deficit at this point in the year, and we're 4 million off plan. I think it's important to note, though, that half of that variance to plan, so we're 4 million off plan, half of that is related to what we describe, and I recognize these are terms that not everyone agrees with, but we would describe those as inflationary or external pressures. So off the sort of £4 million variance, £2 million is how we have described as sort of inflationary or external pressures. And off that 2 million, £1 million sits within our pay position and is related to, in effect, the unfunded pay award and impact of strike action that we previously discussed. And the other half of that sits within our non-pay position and largely reflects to inflationary pressures within agency and provisions and a whole range of other contract issues where we're seeing sort of inflation charges come in much higher than what we've originally been funded for. It's absolutely fair to say these are not pressures exclusively to us. They are generally across the board. And as part of the arrangements for dealing with some of those, the letter that Jane alluded to talked about nationally there was circa £800 million being made available, and we will work through with our partners exactly how we would play into that in terms of trying to manage some of those external inflationary items. Having said that, it still means that there are £2 million worth of reasons that we are off plan because of our that are directly as a result on gift within the trust. So I think it's worth just highlighting that in terms of the pay position, I won't go through the sort of details, but you will see on slide 4 of the finance pack, that we are year to date about £700,000 off the pay position. But it is important to show that there is significant sort of elements within that. We are significantly underspent against our substantive staffing line. You will see that that is not really different to what has happened during the course of the year. But that is then offset by the use of agency, bank and other pay costs, which leads to that 700k spent. I guess the thing that I was going to talk about, but Jane has largely touched on, so I won't sort of repeat it too much, is to say the action that we said we would take to reduce nursing and HCA agency spend is having an impact. And I think it's just important to highlight that. And we recognize there are other factors, and the medical locum spend has sort of taken away some of that benefit. But I think it's important to highlight that because I recognize that some of those controls that we've had to put in place, can feel, especially to staff on the ground, a bit bureaucratic. They can feel onerous. And I think it's right to sort of just highlight that they have resulted in a change, in a significant change. And if all other things had been equal on a sort of full year effect, that would have helped support sort of between £3.5 to £4 million reduction within the agency pay bill. So that's sort of the predominant position within our pay area. So that is the core driver. As I said, we recognize there are challenges within our medical locum spend. We've been working closely with Peter and the deputy medical directors around really understanding where the highest cost locums are and what we can be doing to think about some alternative offers so that we can really start to try and reduce that run rate, because clearly that is not a sustainable position for us. In terms of non-pay, then, as you'll see on that slide 4, clearly a significant driver of our year-to-date position is on the non-pay. I won't list out all of the sort of things that are written there. For colleagues, you will see them, but the drugs, I think it's worth just highlighting because this was raised in a question with me, is driven by price change rather than volume change. Looking at the information that we've got, it's not that we're prescribing particularly more, but it is that the unit cost of those drugs is increasing. We are also seeing significant estates pressures. So our operational maintenance, that is not the element that is capitalized, is significantly overspent this year as we've responded to a number of challenges, I would say across the estate. And part of the solution to those will be the longer term development programs that we're talking about, including the Rises program that will help alleviate some of the issues and challenges. But that will continue to be a challenge as we struggle with access to the what we would consider the appropriate amount of capital funding needed to maintain all of our estate. So we prioritize clearly backlog, high risk backlog maintenance, but that's not to say other areas don't also require elements of maintenance, and that is, I think, as we move into 24-25 will be an area that we will have to think on carefully. I'll come and talk about the recovery section in a moment. I think it is just worth highlighting that part of the reason for our year-to-date overspend is also related to income. The transfer of the Hampshire services, when we originally set the plan, was due to happen in 24-25, has now been brought forward slightly, and we've planned on that basis. And therefore, that is a sort of one-off reflection of that. Going forward, it will be fully planned on in terms of that move. Right, sorry, apologies. I'm on a different setup today and looking at 2 different screens in different places. Okay. So in terms of just the thing I wanted to touch on briefly was in terms of the actions that we need to take. So Jane talked about the letter that we've seen. Those actions, in effect, that we are currently considering will all need to be implemented during the course of Q4. And therefore, we're currently working through QIAs around what that looks like. But those are largely revolve around redeployment into supporting our sort of critical, urgent and emergency care pathways and making sure that those are safe over winter. And we will sort of continue to discuss those with board colleagues through various forums over the next few weeks with a view to bringing them live in quarter four. Chair, I'm happy to stop there if you want me to. I was just going to draw one quick attention. I could, on the timing, I'm afraid. I'm not sure if I'm run over. In the main report, you will see that we've changed how we're now reporting the division. What used to be the old CDS positions, we now report against the divisional positions, as we're now newly structured. So you will see that we've got the West Sussex, East Sussex, Brighton, and Specialist Division. I will say that from next month, we will also report all corporate division as one area as well, so that I wouldn't want that not to be reviewed in the same way. And I think it's worth highlighting because it will align with many conversations I suspect we will have today, that our significant challenge is in West Sussex. It's not to say there aren't challenges across the organisation, but on a workforce front, in terms of the amount of money we spend on agency to cover vacancies, West Sussex is our greatest challenge. That is where we see the greatest level of overspend. If we think that the year-to-date variance in effect is £4 million, 2.5 of that sits within the West Sussex position. So I won't dwell on it further because we'll pick it up through various sort of elements of the meeting as we go on. But as we go forward into next year, I think we'll continue to move to reporting in the line of the new divisional structures.
Okay.
That's it on the revenue position, and I won't pick up the capital positions. I think they're self-explanatory there for now. The only thing to highlight is that from a finance recovery point of view, we have delivered 94% of the savings that we set out to deliver at the start of the year. And I think that is significant. And those are, I will be careful how I say this, but they are genuine cash savings in effect. Our run rate is lower than it would otherwise have been if we had not delivered those savings. And I think it's testament to recognizing that we'll need to take further action over quarter four. I think we start from a position of being able to demonstrate that where we take focused action, we do get the delivery.
Okay, thank you. Are there any questions for Usman? Kevin.
Hi, Usman. I don't think anyone would envy the particular task you have right now at this point in the year, and also I genuinely want to say well done to everyone who's managed to get that 94%, because I can just imagine that, you know, the multiplicity of tasks required to get that far. My question: you mentioned sustainability in your speech, and I guess my question has to do with kind of the culture and the devolved nature of one, leadership, and two, kind of spending controls down into the organization. I'm mindful that a lot of the actions we have taken over the past 18 months have been a little bit top down, and quite a lot top down on occasion, you know, spending controls, do this, don't do this, and also that the current actions are indeed by necessity top down for the rest of the year. But you know, next year is upon us, right? And mindful that the external audit said that our managers weren't necessarily the best at budget setting and necessarily the best at there was a gap, if you like. So I guess the plan to devolve budgetary responsibility and genuine ownership down and through the divisions and into, you know, front line, if you like, and that sustainable piece when it comes to the culture of spending what we've got on the best possible stuff. And I guess it's the flip side of how we develop services bottom up, if you like. So that's a very long question, but it's the sustainability of that aspect of culture.
Yeah. Thanks, Kevin. I mean, I think it's a great question, and one I've been, well, as a whole exec, we've been talking about a lot over the last few weeks. So I think some of the actions we've taken are quite top down, and I think in particular around agency controls, vacancy controls, by the nature of where we are, I'm afraid, I guess I haven't thought of a better way yet of being able to, in short term, get some of those results. But I'm the first one to accept that those are not long-term sustainable ways to run businesses or to run a hospital. And I think one of our sort of, having now got the new divisional structures in place, having recruited people into them, I'm very much of the view, how do we rely on the 6,000 people who work in our organization to come up with the ideas, to be trusted in effect, and to be, given that responsibility to say, this is the set of envelopes that we operate in, whether they're funding, whether they're workforce, and how do we deliver that? And it's sort of our job to support them and enable them to do that, I think. I think by nature of where we've been in the journey over the last 18 months, we've had to sort of start from a position of taking a bit of grip and control. We've had to get to a position where we're really clear what's driving that sort of underlying deficit, which I think we have done. And now as we do start developing 24-25, it will be very much down to how do divisions think they can do that? What would it take? And how do we then support them, I guess, as a corporate function? Because that's what we're here to do. Our job is to support them and make sure that they've got everything they need to do what they can. And I guess just the last bit I'll say is, this has been a whole sort of team effort. And while some of the things we've done top down, a lot of the actions that we're going to be taking through Q4 are actually actions that have come directly from the teams themselves. We've engaged quite a lot with our newly constructed senior leadership team, the new divisional triumvirates. And I think the sort of benefit of having put those structures in place earlier this year means that when we do face sort of challenges like we are now, we've got a ready-made sort of infrastructure to go and then engage with and get the ideas from and support of that sort of next tier of senior management down.
And what's going to change in West Sussex?
That's a great question, Chair. I think our key challenge in West Sussex. So in West Sussex, what's changed? Recognizing the workforce shortages are particularly extreme there. We are now piloting a range of enhanced incentive offers only in West Sussex and within the specific teams where we've got the highest vacancy challenges. I won't go into all the numbers, but in effect, the set of incentives that we're offering in West Sussex now, I think, put us out definitely into the very top end of the most generous incentives we're offering for permanent recruitment into registered posts. And that's both across medical and non-medical, I should be really clear. I think one of the other things that we're doing is taking a really close look at all the services that we provide in West Sussex and being quite clear around what is it that we have to provide, and we have to provide really well, really safely, and what are other things that we potentially have to make some longer term decisions around in terms of if we only have a finite workforce and we are struggling to recruit, then what are the things that we have to absolutely prioritize? I think one of the other things that we're really focused on is understanding variation between West Sussex, East Sussex and Brighton. The advantage of being a one trust that operates across the whole county with three separate places is we do get some sense of understanding what unwarranted variation looks like. And that review of unwarranted variation in terms of variations in referral pathways, in terms of care delivery models, has identified that actually there is quite significant opportunity for us to be able to make improvements, both in terms of moving workforce into areas that are slightly different to what they do now, but also getting some of the best practice that's happening in part of the other areas. So those are some of the sort of the things that we're focusing on, but that's what we'll be developing as we move into 24-25.
Okay. And when will we know whether that approach is starting to work?
I'm hopeful that we will know by the end of Q4, because those actions we're starting to take now, and if we don't see those being sort of results coming through in the fourth quarter, then I think we're going to have to take a really hard look at.
So we need to look at that you'll need to look at that at April. What is effect? I think April board, because I think it's the first week of April, isn't it? Yeah. Okay, if we can make a note to do that. Teresa.
Thank you. So I'm just reflecting on what we mean by top down. In relation to the work that Pete and I are really closely connected with clinically. and working really closely with Usman and the teams in making sure that these challenging times are faced by us absolutely prioritising quality, so safety, experience and effectiveness, and squaring that off. So the quality impact assessment process, as Usman said earlier, is in train. The triumvirate gives us that additional level of assurance in terms of having the divisional directors of nursing and quality, the clinical director and the managing director working really closely together in how we operationalise those changes safely, and again with the absolute focus of safety, experience and effectiveness. And then I was thinking about this example that we've spoken about just now, so 400,000 saving in nursing agency, but at the same time triangulating that with our reduction in vacancy for nursing, and I know we'll hear more about that, and also then within that the monitoring of the fill rates, because the fill rates on our wards aren't affected negatively. So our fill rates from a safe staffing perspective are where they need to be. The nursing vacancy is coming down, which is great from a safety perspective. And at the same time, we're saving 400,000 in agency for nursing per month. It's just important that I share those reflections with us all to illustrate the connectivity between the quality being the absolute priority here and the efficiency that we must find.
Yes. I think we go through phases where the NHS can feel that it's all about accountability, and we mustn't forget the authority that we have as a board to make sure that we are focusing on quality as a way of driving the run rate as far as we can. For me, you had a hand up.
I did, Chair, and I put it down because I was going to say exactly what Teresa has said around how important it is for us to use our quality performance review meetings to really pull together the triangulation of what's happening around quality, performance, and effectiveness and safety, but also the fact that we use those monthly meetings as a way to drive where we need to change something. Yes. And then we look at what impact that has had when we come back the next month.
And it's where top down and bottom up come together. So
correct.
Quality improvement
so really
and grip come together. Yeah,
that's
Peter.
Right.
Thank you for me, Peter or Pete. I don't know.
Yeah, thank you. And I think it is worth sometimes sharing with board the fairly granular experience of conversation with potential clinical leaders. But Jane and I have hosted now 2 roundtables with coffee and croissant and consultant colleagues, with a 3rd round to come in the new year, really just to listen to them talk about their leadership ambitions, some of the barriers that they see to having their voice heard, how it might be that they could take more accountability for leading us through difficult change. But what came through in those conversations wasn't a sense of resistance or an adherence to some historic past, whereby they would be rigidly within a catchment area or be rigidly within a service. Rather than that, I think we heard a couple of things. One, the value that they place on face-to-face consultation with patients. Secondly, the value they place on multidisciplinary teamwork and the importance of reacquainting themselves in the depths of multidisciplinary work rather than being consultants to sometimes feeling disparate teams. But third, a genuine appetite to work differently, given the test of, so we maybe need 250 consultant psychiatrists to serve the old model, but what if we only had 200 consultant psychiatrists? How could they best service the current population of Sussex? And they were very open and attracted by having that different conversation, and they completely understood the inequity of some of the locum arrangements that we have in place. And I came away from those conversations feeling that as we move into the new year, we are rediscovering a relationship with our consultant cadre, which I think is going to help the other professional disciplines exercise their clinical voice in making these changes. What I'm not picking up is a sense of despair at that level, that these are unmanageable cuts of some kind. They understand the need to transform faced with a different demography and a different set of health needs. Now, that's not to say that we won't face the usual resistance and anxiety from people working in services and service models that come under pressure. People working in those services are naturally going to find some of the changes proposed difficult. And therefore, it'll be pulled upon us as clinical leaders to hold that anxiety and see people through and hold the patient in mind, because it will be bumpy, and the board need to come with us in plain sight on that journey. This is not an easy thing to do. There will be criticism. Things may not always work out very well, but I think the body of the Kirk, if you like, is on it, and there is a genuine sense of coherence from board to floor that there's no alternative to tackling this. There'll just be some issues about where we start to make the adjustments.
I absolutely agree with you. The board need to come with you, and it goes back to the point. It kind of relates to the point that Joe was making, that actually we also need to be thinking about when we literally come with. When is something purely executive, and when is something actually a board engagement, and when we need the whole board to be engaged in some form in those exercises. But we also take some reassurance for the moment that there's a willingness to engage and a willingness to have the conversation in terms of this being clinically led. I'm going to draw a line there. Thank you very much for that conversation. We recognise the pressure that the exec are under. I think we also have some understanding of the number of calls that you're being called to, whilst you're also being asked to get on and deliver. I think we feel that we've got some indication of improvement and some desire both to generate suggestions from within the workforce, particularly the clinical workforce, but also that we are exercising the right degree of grip and really pushing where there are both understandable and unacceptable levels of variation. So thank you for that. I think that takes us into the integrated performance report. And I think what I was thinking we needed to do today was particularly focus on where quality is a driver of the run rate. And actually, yes, we get some assurance that we have got that grip. You've covered much of this already, Usman, Teresa, and Peter. So I'm not asking you to repeat it, but if there was anything you wanted to draw out of the integrated performance report, then obviously we want to hear that.
Thank you, Chair.
When I said Usman, Teresa, and Peter, I meant Usman, Teresa, Peter in front of me. I apologise. Sorry.
Thank you. So, I, as you said, I think some of the things we have covered off, but there were a few points I just wanted to draw to everyone's attention, I guess, because I think it speaks to that agenda in terms of how are we managing things in the context of needing to make the sort of improvement in terms of run rate savings. How are we still ensuring that we're safe, that we're providing good quality care? So over SIs is the first point place I just wanted to touch on within the report. It's sort of the section is there on page 7 of the actual IPR, but just to highlight that at the point in September, I think it was, or August even, we had over 25 overdue SIs. The total number of SIs we have has stayed relatively consistent, but the number of overdue ones was high. And I'm really happy to report that as of Monday, we had 1. So I think the improvement in terms of our ability to make sure that we are responding in a timely way to serious incidents, and more importantly, learning the lessons from them and sharing that learning is really key. I think as we move through now into the new PSERF approach to things, there is, that learning is embedded within it. But I thought it was just highlighting, because I know that when we've talked about this before in terms of that persistent level of sort of overdue and how do we need to do things. And I know Teresa can sort of possibly we'll definitely talk about it in more detail, potentially around the work that she has done with her deputy CNO around the process and making sure that we've got the right focus around it, they're going to the right places, but most importantly, that we get the learning out of it. I won't dwell on it, but it would feel wrong not to mention that complaints as well. Again, February 23, we had 65 overdue complaints. We're currently at 1 as of Monday. And again, I think demonstrates not just that we're closing them, but we're also trying to learn from them and making sure that we are then feeding that back to those relevant teams so that they are getting that learning. And again, I think the new divisional structure makes that a lot clearer. It makes it much simpler in terms of knowing where responsibility is and having the management capacity, because I think that's one of the things we've got to recognize is We have expanded that through the divisional structures, but that has allowed us to then address some of these quite significant long-standing challenges. Just to briefly then sort of a couple of other points I wanted to come on before I talk about inpatient delays. Risk assessments, care plans. You'll note that the very in-month number appears to be very low. I hope the explanation in the packs is clear that the most current month is always delayed, and so looking at the previous month is more important. And 93.1% is currently reported for risk assessments. We do expect post sort of the late recording corrections to actually increase to about 94% against a trajectory of 95. And that's not to be complacent. We recognize we've got a particular challenge in Brighton and Hove. There is a recovery trajectory with that team. And I know they're taking that seriously. We monitor it through the quality performance reviews, but we're confident that that will result in us getting, hopefully, to target. And then same for care plans. We recognize again the challenge there is within the Brighton and Hove division. There is a recovery trajectory and plan in place. We are meeting with them regularly to understand the very specific actions we need to do to enable them to get there. But generally good performance across our other divisions. I will leave the workforce sections to Funmi, if that's okay, Chair. But what
that would be very appropriate.
What I wanted to just touch on first was around the inpatient delays, and I guess it's especially as we now start disaggregating our top line data by divisional positions. Slide 9 of this does start to draw out and make clear where we have really particular challenges within our inpatient delay. So the terms are, forgive me, colleagues, but the terms are used interchangeably as either inpatient delays, clinically ready for discharge, or medically ready for discharge, but in effect all mean patients who are ready to be discharged, and we are waiting on normally local authority partners amongst others. And I guess we are going to have, Jane mentioned it, but as of today, we're roughly 110 people medically ready for discharge and 60 people waiting for an inpatient bed. And I guess the reason I want to start with that metric is because right next to that metric is the total number of people waiting for a bed. And you can see that that has been rising over the last 3 or 4 months in particular, and the two are clearly correlated. We have had over the course of this year on any given day 100 on average there or thereabouts people waiting, but with 100 beds ready for discharge, but with somewhere between 60 to up to highs of 80 people waiting for beds. And I think we've also got to recognise that we have got real specific challenges both within West Sussex and Brighton in terms of the delays and the reasons for delay. And in particular within West Sussex, it's not just a number, but it's the length of time they wait. So as part of winter planning, as part of the work we're going to have to do via the Quality Summit, I think that is where we're going to have to put our focus. And it's not to say that this is about blaming other people. We recognise the pressures but authority colleagues are in, but it's important to draw that link between those two things in terms. And
I think Usman, I think post Quality Summit, I think the board needs a whatever you want to call it, a briefing, a deep dive in terms of understanding what's in our gift, what's in the NHS's gift. How can we reframe? What can we reframe, as well as how can we come up with a new relationship with our local authorities? And I know that's all in mind, but I think in January we do need to put some focus there, because it does go back to the problem of, can people get in when they need to get in, and can they get out when they need to get out? And I know that's a simplistic summary, but I think we do need that focus post Quality Summit. I think that would be really good. I'm going to stop you, Usman, there, okay? Because I've got a number of people with their hands up. Now I'm going to go to Pete and Teresa first, then I'll go to Nitin, and then, as you suggested, I'll go to Funmi. Okay, Teresa.
Thank you. So the only thing that I was going to add in terms of quality, so the IPR will become an IQPR, and we're just working up a whole range of other quality metrics under the umbrella of safety, experience and effectiveness. Those will be reported through Quality Committee. That coupled with, and the point that you've just made, Peter, about the quality summit, will then help to influence and inform our quality plan priorities into next year. So more to come on that through meetings in the near future.
Yeah, and as the board is clear, the quality plan is what actually delivers the financial plan. I mean, because that's the driver. So we do need to schedule. When do you want to bring? Because I think again that would be good for a board development session. It's currently scheduled for March. Is that right, or can it? I mean, I can't hear you.
Oh, I don't know what happened. Sorry. I was saying we'll take that through the quality committee.
Fine, thank you, Pete.
Thank you.
Yeah, thank you. So I think one of the currencies that we've been missing as a trust and as a system is a recovery currency. And by that, I mean our patient-reported experience measures, our clinician-reported outcome measures, and our patient-reported outcome measures. And whilst it's incredibly important that we have these things for commissioning and provision, probably the most important place for these conversations is between partners. Because what we end up with is us saying that somebody's clinically ready to go or medically ready to go. And the next place in the system says, yes, maybe ready to leave you, but still too sick to come to us.
Yes, absolutely.
And I really want us to get our evolution of PREMs, PROMs, and CROMs not only right internally, but also right with our systems partners through the transformation agenda. Now, the good news is we're letting a number, I wouldn't say 1,000 flowers bloom, but we're letting a number of flowers bloom, which means on a monthly basis in our quality performance review meetings, we are now hearing our divisions talk to us about their journey to get to these things. In our weekly quality report as an executive team, we are also getting information on how that journey is progressing. And we're now putting those two teams in closer touch with each other so that pretty quickly, by the time the report Teresa's referring to comes around, we will have an aligned weekly, monthly governed review of that journey. But it's just to really explain to the board that in 3 months of work, we've come quite a long way. Now what we need to do is think about how we take that out into the wider system conversation to make sure we're not inventing pounds only to discover they're operating in shillings.
Absolutely. If we don't have a shared understanding of risk and a shared understanding of quality, we can't shift the pathway. Now, so John, I mean, I think what I'm going to suggest is if we I mean, the inpatient delays, which we can badge in, I think is something we'll look at in some detail post quality summit. But was there anything you wanted to add today?
Thanks, Peter. No, I mean, Usman and others have covered it, really. I think your question is always the pertinent one around what is within our gift, what can we be doing and what can we be working with partners to do. And I think it's probably worth just rehearsing all the work that has been done within the housing space, the development of the housing workers, the development of our tenancies, supported tenancies, the plans that we have around different models of care. And we have seen a reduction in housing-related delays, so general needs housing-related delays. The struggle and the challenge that we continue to experience is around supported accommodation, and that's where our focus of attention will continue to be. Apart from that, Chair, I'm happy to take any questions, of course, but I've got nothing more to add.
Okay, and I think that's some of that we can tease out when we regroup around inpatient delays in the new year. Thank you. So I've got Nitin and Funmi and Dan. I have no idea what order I've got those in, so I'll go to Nitin and then I'll go to Dan and then I'll go to Funmi, and that will be the final word on this part of the meeting. Nitin.
Thanks, Chair. I was just curious and would love to see, and there's a mention of the balanced scorecard on Power BI, which is translating some of the performance reporting into it. Would love to see what that looks like and whether this is like a complete transition of just the IQPR into a balanced scorecard, if there's something else in there. Yeah, just curious to know how that looks like.
I'm happy to. Oh, sorry, Chair.
All right, Usman. Okay.
I was just going to say, Nitin, I think it's not a complete sort of just lift and shift of what the current IPR is. So we have tried to do it differently. I mean, it brings across many metrics. I guess maybe outside of here, I'm happy to share that.
I think it's probably better that when Shariza's, well, whoever it is ready, that we bring it and then we talk about it. But the point, I think that the point is heard, that you're asking to see something that looks at it in the round. Dan.
Thank you, Chair. Very briefly on complaints, tone and timeliness of response remain key areas of focus for us, as the board is aware. Next phase of our improvement programme includes focusing on the quality of complaint investigations, learning and action, and we'll bring that back to board as part of our future quality updates.
Thank you. That's helpful. On me.
Thank you, Chair. Just to very quickly on, I thought I'll start with some good bits, because it's been quite difficult so far with everything on the workforce side. So with our vacancy and turnover, you will see from the IPR that it is showing plans that we have as an organization. But I thought it would be really important to share that for the first time in 13 months, and that's because we look at the data going back every 13 months. For the first time, the trust is able to record a number that is below our overall trust target. So we had a vacancy target of 14.5%, and we've come to 14.37 in what has been a continuous reduction over the last 6 months. And I just thought it was really important to mention that to the board, so we can see that a lot of this hard work, it's slow, but we are making progress. That's also the same thing for our turnover. The turnover when I came in post was recording almost 18%, and we now have the turnover sitting at around 15% for our trust-wide, again, very close to target for our trust-wide numbers. Now, that said, Teresa's already mentioned the progress we've seen around our medical and our nursing vacancies, which has historically been the largest, and it still is our largest area of focus, with our consultant vacancy at 28%, and our nursing has been at a steady over 30% forever. For the first time, that's broke the 30%, sub 30%. It's now gone down to 27%, and we now have a detailed workforce plan where we can match the activities to the target to try to get us to a position of 25% by year end. So that's by March 31st of 2024. And there's some other activities, that we've all talked about on this call that should hopefully see us even go below that. But really important to mention that at board, so that, especially if we have people listening, that there is some hope and confidence in all of these activities and initiatives that we are taking as an executive, that they do have targets linked into them and their activities linked into them, for us to be able to see some of this progress across that. So that's the bit I just wanted to say around the good news part. And in terms of our supervision and appraisal, you'll see that those two numbers we have struggled with as an organization, as a trust, but we have made considerable effort, because one of the things we recognized was that our corporate division was responsible for a significant proportion of our poor performance across appraisals and supervision. So as an executive team, we decided to take action to focus on that over this past quarter. And in the past quarter, we have seen the overall supervision and appraisal numbers for the corporate division almost double. So that's the one that sat at about 30-something%, now sits at 62%. And if you look across the 4 key divisions, corporate is still lagging behind the 4, i.e. our place-based and our specialist division. With regard to the specialist division, they all have individual trajectories that has been signed off by the Chief Operating Officer. with the trajectory that reports back into our QPR for us to support and monitor progress. But also with regard to what I have oversight on is the development of a new digital appraisal form that we expect to go live, fingers crossed, in January of 24, that will definitely pick up some of the experiential reasons why we have problems with people completing their appraisals and recording them, but to also provide support around what a good conversation should look like, and examples that people can follow, and it will send reminders and all that sort of what you would expect to be basic things that we haven't had before now, but we will now have in place by January of next year. So we expect to see that have an impact on our numbers as well. And the last thing I wanted to just touch on were two things. One was on our sickness rate, which is the only one that has always been very seasonal. But I just also wanted to mention that the part within that seasonal fluctuation has been our long-term sickness absence. And for the first time, we are seeing a reduction in our long-term sickness absence. And it's always that thing I say around correlation, causation. But I do believe that the work that we're doing around our retention efforts with regard to well-being, health and well-being, is beginning to have an impact. And the thing with this impact is it'll probably take a bit longer for us to see the fuller impact of it, but we are beginning to see the impact on that as well. So we've had another decrease in the month of October, with us being very close to target. And I'll end on the note of saying that whilst the significant amount of activity, so everything I've talked about is around activity, whilst a significant amount of activity is happening, it does continue to point to the fact that the biggest work we need to be doing as a trust, and we need to all have our support behind, is around our retention work, because right now it has been like a revolving door. So we do a lot of activity to get people in, but we're losing them. So that activity is like being in a hamster wheel. So it's about now really focusing on our retention part of our work to give us some assurance as a board that not only are we doing the right activities to get people in, so whilst it's good that our vacancy numbers is going down, what we do need to keep a strong eye on is our turnover numbers, because that really is that litmus test for how well we're doing on retention. And that's one area that I want to really be unpicking as we come to board in subsequent quarters. So the quick whistle-stop overview for me.
That's really helpful.
And I'll pass back.
Thank you for me. Kevin.
Thanks, Zoe. And on that note, and I was taken with your metaphor around the filling a bathtub that was leaking or something like that at the last audit committee. Question was, you were going to look at a deep dive into exit interviews and trying to get more data and information about that, really kind of the gold dust that people actually have left while they're leaving. And will we be seeing an output from that?
Yes, we will. Thank you, Kevin. We will be seeing an output, but I think the output has revealed another gap, which again is our system. So we haven't before now had a good system for collating those exit interviews. So by the time I did a deep dive, my deep dive revealed that we had about 100 exit interviews in this financial year. That's the number of people we lose in a month. But that's the total number of exit interviews that we had for the 1 year, almost 1 year, because we're now in November, for the almost 1 year period, which for me immediately reveals that, okay, we need a better system for collating exit interviews rather than a survey monkey, which is what we have right now. It's not, poorly put together, if I can say, form. So it's again revealed something, but yes, we have 100 data points to look at, but I think which is not good enough.
Thanks for me.
Okay, thanks Funmi. Is there anything else particularly for Funmi? Okay, so I think we've had an update on the financial position and the measures we put in place to deliver the various promises we made, and obviously being 94% towards the desired target we need to recognize is a major achievement. It's going to get harder in Q4, and we've heard some of the steps that we're putting in place to try and make sure we stay on track, because the more we can stay on track in 23-4, the easier 24-5 will be. Not that 24-5 is going to be easy, but it will be easier if we can do that. I think that there are some really important points about really wanting to focus on quality as the key driver, and then on both retention and well-being of the workforce as well as recruitment. So thank you for that. I apologize that we're running over time, but I will do my best to get us back on track. Can we now please move to the strategic review of the breakthrough objective? I'm conscious we've covered some of it in the previous conversation, but I still think it's worthwhile looking at it as a breakthrough objective in its own right. And I think it's Funmi and Colin that I'm looking to.
Thanks, David. I'm going to take the lead for the conversation and then bring Funmi in. So I will do a whistle-stop tour in terms of the slides that we pulled together. So the breakthrough objective.
Take the time you need. We'll manage.
Thank you. Okay. So this is the breakthrough deep dive into partnerships, which is obviously about working with partners to improve the quality of life in the communities we serve. Next slide, please. Can we go to the next slide, please, David? So just whilst we're waiting for that to move on. So obviously within this breakthrough objective, there were three kind of key areas. Thank you. The first one is very much around looking at improving our relationship with the voluntary sector. And this is just a summary slide that shows that the milestones are on track for that particular kind of area. The second area of focus is very much about, we've been talking about quite a lot in terms of thinking about how we work differently with the voluntary sector, and doing that to help reduce some of our vacancy rates through developing new models of service, new models of delivery, which help to reduce our workforce, because we are starting to deliver in partnership with other organisations. And a third one, very much as we talked about before, being very focused on the kind of the housing related delays. So it's the first two I'm going to go into just in a little bit more detail. You'll see all bar one are currently on track, and I'll come back to that in a moment. So just for the board to note that in September this year, we signed the first working together agreement, or the Sussex Compact, which was signed by Jane, along with 7 of our VCSE mental health strategic leads across the system. This compact sets out our collective intentions in terms of how we're going to work differently together on behalf of the local communities we serve, but in the spirit of working collaboratively and with a sense of kind of equality and respect for each other. I think it was a really important document that we sort of signed because it signals our intentions as an organisation, and it's underpinned by a number of principles and commitments that we've made. Fundamentally, the 4 I drew out at the bottom of the slide are around this sort of strapline almost, that we might be 2 different sectors, but we can work in one partnership. The fact that we recognise that we have difference, but actually that we will be stronger and deliver more benefit if we are collaborative. It was really important, particularly for our voluntary sector partners, to really recognise a sense of kind of equity, and that one voice isn't stronger or better than another, and that we are completely equal in all the work that we're doing. And then there was conversations around needing to really think about honesty, particularly around things like the financial climate, how sometimes we go about doing our business, which makes us harder or less accessible to engage with, and also a real sense of kind of growth mindset, and that this is very much the starting point for us as an organisation and as a system, but there's lots and lots that we want to do collectively over the next sort of 2 to 3 years. Next slide, please. So one of the ambitions that we talked about in the breakthrough objectives was thinking about how do we work differently across some of the particular areas? So this is about transferring roles to the voluntary sector. So this gives you just a very high level breakdown in terms of where we've identified roles in a range of different areas across the services that we're working towards transferring to the voluntary sector for delivery over the course of this year. You'll notice in particular, the second line down refers to peer and support workers in crisis services. So I think this plays into kind of conversations and stories that we've heard previously about the value that it would be that when people are in crisis or when they're moving from inpatient care, havens, crisis services into ATSs, that actually there's someone there with lived experience who's able to kind of walk that journey beside them and really help them understand, A, what's going on, but also thinking about that sort of local support and accessibility piece as well. We're really keen as well to make sure that we're sort of spreading the benefit or the opportunity here. So thinking about where are the opportunities from a kind of an adult service perspective, but also particularly thinking about opportunities around our children and young people services too. And again, with a kind of focus around that kind of crisis pathway, which is often where we hear the experience of young people and adults. The experience can be most fragmented because often there are multiple different touch points or handoffs that people are kind of sort of experiencing. So the time frame now we've identified those roles is that we are in the middle of just developing with VCSE partners exactly what these roles need to look like, with the intention that we'll be mobilising by the end of this sort of financial year going into next. Next slide, please. I just wanted to bring through just two case studies, just as an example for the board, in terms of kind of sort of where we're starting to do some of this work and some observations around both what's going well, but also what's the experience in terms of sort of more challenging. Because I know at the start of the year, we talked about 30 roles. That seems a little bit under ambitious maybe. But I think because there's so much work in the background in terms of the cultural changes needed, and also the transactional changes for us as an organisation, that I think it's important to start small, really get the learning right, so that we can then scale quite quickly over the coming year. So this is just an example where we're in the middle of rolling out some voluntary workers into the rehabilitation services in kind of sort of West Sussex. We've identified 4 workers, and we're currently sort of going through mobilisation at the moment. One of the things that's been really heartening is the fact that in terms of kind of what goes well, there's a real appetite and a thirst from our voluntary partners to be able to kind of work with us to try and sort of develop these ideas better. We've had a really good engagement, both in terms of some of our internal teams, because there's a lot of things that we have to do internally to make this work as well, whether that's thinking about the contractual frameworks within which we're trying to operate, or working with our digital partners in terms of thinking about how do we have one patient record rather than fragmentation in terms of how we're capturing information. But we know that some of the challenges that we've kind of sort of teased out and experienced are things like, you know, really understanding the full cost for the voluntary sector to be able to kind of host these roles and work in this innovative way, particularly when they work with very small margins and overheads. We've got further work to do in terms of sort of governance structures within our organisation. And I think there's often this tension or this challenge between the day-to-day service pressures and the urgency of managing today with the sort of the ambitions, if you like, of this programme of work, which is more future focused and takes time and energy and effort to kind of keep it on track. Next slide, please. One area that I think, you know, has been really, really good to see, where we've made some really good progress, is obviously with the establishment of the Brighton and Hove Staying Well service. So many of you will know that there has been a pre-existing service provided by Southdown for a while now, but it was provided in isolation of the rest of the kind of crisis pathway, and wasn't an open access service. So you had to be referred into it to be able to kind of sort of walk through the front door. We've worked really, really hard, and the team certainly has done over the last kind of couple of months to move this to being an open access service. So we now co-deliver it with our clinical, non-clinical staff and staff from the voluntary organisation Southdown, in a way that means that actually if people in Brighton have a self-defined crisis, actually there is a front door that they can go through that is an alternative to A&E in the evenings and at weekends, and they can receive support, which may be clinical support from a professional, but may also be kind of sort of peer support or voluntary support. Again, what we've observed from this is a really good engagement and some real desire to collaboratively work from the voluntary sector. We've already got some vignettes and some case studies that have shown some real benefits for people, particularly those that have been diverted either from or away from the A&E department in Brighton, sorry. However, in terms of challenges, one of the things that we're really noticing is that cultural piece around bringing, what are traditionally two quite different cultural groups of people together to work in a different way, in an integrated way, with that sort of sense of mutual respect and benefit. Next slide, please. The other kind of sort of area within this breakthrough objective was very much around the kind of the housing piece. And I think, this slide is kind of well rehearsed now, that we've seen some really considerable improvements in terms of the number of people who are experiencing delays within our inpatient facilities as a result of housing reasons. Now, I want to be really clear here that we're talking about housing as opposed to supported accommodation and all those other factors that are also an influence in terms of sort of the delays. A lot of this has been driven by the fact that we've really started to look at the skill mix difference. So actually, if we bring housing workers who could work across the local authorities into our inpatient units, etc., and really start to think about housing as being, part of the formulation right from the start, rather than just, focusing on medication and therapeutic interventions, and then housing only becoming an afterthought at point of discharge. And we can see the benefit already. Next slide, please. Some of the other areas where we can start to see this change in relationship with the kind of the voluntary sector is through various different things, like we've now gone live with the supported tenancy scheme, where we've got 3 tenancies in place at the moment, and 2 more planned in this year. So this is about how we can help people in a different way that we might traditionally to kind of get to receive and to be able to have their own tenancies. We've got a community support provision that we're working with a voluntary sector organisation with in West Sussex to try to help that discharge pathway. We've also supported the development of the recovery beds in coastal West Sussex, which I'm really pleased to say have gone live a few weeks back. And last week, ourselves and Southdown co-hosted an event with a range of different housing supported accommodation providers in Sussex to really think about how could we work differently together to try to alleviate some of these adult pressures, where we're not just thinking into, do we require more mental health beds, but actually how could we really leverage some of our partners in creating the solutions rather than us sort of creating them and sort of kind of going and telling them. And the last slide, please. And this is just a quick summary, and there's a health caveat, if you like, in terms of this was literally pulled together on Friday, but it just starts to kind of give a bit of an indication around some of the things that we were talking about with our voluntary partners around what are some of the difficulties that they experience. One of the ones that we're continually sort of challenged by is the NHS is slow to react to building-led opportunities. We're quite we're quite short-termist in the way of thinking about things. But actually, what are some of the ideas that our partners can come to the table with to help us think about differently, and what would be the outcomes that we'd be seeking to achieve? So I guess that's just a kind of sort of brief summary, if you like, in terms of a range of different areas of work that we're doing under the kind of sort of the partnership banner, if you like. The next kind of sort of big milestone for us will be at the end of this financial year, when we'll go back out and do the stakeholder perception survey again with our kind of sort of voluntary partners, to just see whether or not there is that sort of felt sense of us starting to be a different partner in the system in terms of trying to deliver some of these outcomes. Happy to take any questions.
Okay, thank you very much. Are there any questions for Colin or for me? Anna, please.
Okay, I was just going to ask if I could just quickly jump in on...
Oh, okay, sure.
Yep. All right, brilliant. Now, I just wanted to mention the levers that, from a workforce point of view, to support slide 4 that Colin had up there in terms of how we actually create those, which ties into our people and culture plan, which we'll talk about later. But I just wanted to flag 2 key things that I think will be that I know will be very critical to helping to make that happen. And one is our new roles. The new roles is the plan to create a new way of working, as Colin's mentioned, and an example is our housing specialist role. We have, with the new role strategy, successfully introduced 243 roles in the last year, with 107 trainees employed in new roles training posts. So what this means is that this is a real opportunity for us to use that same approach of new roles to think about culturally with the teams roles that we could then have moving out, having already successfully showcased that this is something and an approach that truly does work. And the second thing that I wanted to mention was just around the culture bit that Colin mentioned, which is around getting people to think differently and moving along as opposed to sort of holding that vacancy, is that we're doing an establishment review. And what that simply means is that we're looking at an overall review of our posts and the roles that we have and the jobs that we have. And as part of this is a really good time for our organizational development team to come alongside teams to be able to go, well, this particular post, you've had it vacant for a year. Could we look at it in another way? Do you really need that? So it's a two-part opportunity there that helps us to support this reaching those targets and potentially doing more with it in the new year.
Great, thank you very much. Anna.
Just very quickly, because I can't stop my enthusiasm for this. I think it's absolutely brilliant. I think it is the kind of future model. I think we have to two things. We have to show the evidence. So I think it's slide 5. If I got the right one, the mental health and housing slide is just such a brilliant example because it shows actually what this is doing. But the second thing is, I feel like we have to talk about power and the fact that we are relinquishing power and that we're prepared to do that because we're doing it in the interests of the people we're here to serve and the communities we serve. Because I think people in the voluntary sector just think the NHS is all about hanging on to everything. So this, to me, is a brilliant example that we can use in all sorts of places to say, well, actually, no, this is not what we're about. This is something different, really different that we're doing. And here's the evidence. So I'll shut up now. I could go on for ages, but I'll be quiet.
Thank you. Kevin.
Equally enthusiastic here as you can guess.
Oh, no.
I know, but I'll be succinct. Yeah, no, really good start, right? Really good start, and doing what we say we're going to do really important. And just, Colin, just hoping that we're capturing kind of the meta lessons from each of these use cases, and that we're, turning that into something that we will use for the next engagement and the next problem. And those problem statements will get wider and deeper. Yeah, and let's devolve. Thank you.
Brilliant, thank you, Peter.
Thank you, and thank you, Anna, for making the point about letting go. It's very interesting speaking to staff groups elsewhere about the letting go. It is about letting go of the anxiety, I think, of feeling responsible on a statutory basis for people that are moving into a sector for which they have no overall control or necessarily a history of a trusting relationship. And I think working on that reminds me of a period over my career where consultants let go to junior doctors. Junior doctors eventually gave way to letting go within the multidisciplinary framework. It led to new ways of working for doctors and other professionals where we were held to account for our clinical work as autonomous people within systems of care. I think this is a natural extension to that journey, but not to be overlooked. And to Funmi and others, the cultural piece here, whereby it's easy for me in suicide prevention to know this because we've reached out and worked with the third sector and voluntary organizations for a bit longer. But it's really interesting that the time it takes to get a confidence in one another, that we're not holding on for any other reason than anxiety, and we're not letting go for any other reason than a lack of confidence and trust because we haven't worked well with people for long enough to know it. So it's very important work. It's soft skill stuff, but it's not easy. But thank you for raising it.
And it goes back to your earlier points around a shared understanding of risk and a shared understanding of quality that then enables people to move across organizational boundaries, doesn't it? Joe.
Oh, this is just brilliant. But the question, just wanted to make a link with digital technology and how we tie that in terms of the workforce aspects and the culture change and freeing up our staff so that they can concentrate and focus on much more tailored and personal solutions in working with our service users. And I know, Gurpreet, that's come up in some of your papers, but it'd be good if maybe not today at some point to have an update on where we are with that.
Well, just looking for the hands up button, but I'm happy to respond.
We are scheduling that, Joe, for the new year. So it's very timely. Thank you. All right. I think, Colin and Funmi, I think you get a sense of the enthusiasm, through the meeting, inpatient, the length of time people are spending as inpatients has been a theme. And I think this shows what we can do, notwithstanding some of the issues that we've got to do in terms of building trust and letting go of some of the traditional roles that we've had. But I think it is a really good step in the right direction. And as you can sense, the board is very, very supportive of this. And also, I think it'd be interesting to then start to think about, well, what are the other areas we might be able to move into in a measured way. But thank you very much for that today. I'm conscious of time. In terms of emergency preparedness, resilience and response, John, I think there are three things you wanted to highlight. Is that correct?
That's correct, Chair. You happy for me to go ahead?
Yes, please.
Colleagues, this is the annual statement of compliance that we are we're required to bring through the public board each year. This describes where we're at against the NHS England standards, and as you can see from the paper, we remain at a substantial compliance. Mental health trusts have 58 standards that they have to fulfill. We're fully compliant with 52, and we are partially compliant with 6. What does that mean? So in terms of challenges over the year, I think probably the most significant challenge has been our focus on two things. One, the ongoing management of the urgent and emergency care pathways, and secondly, the management of industrial action, whether that's been doctors, nurses, or any of the other industrial action that we've experienced. And we have received very nice and positive feedback from system partners as to the management of our industrial action. So credit to those colleagues that have been involved in it. However, that means there are some areas that we need to pay greater attention to in 24-25, and you can see the actions laid out in the plan regarding each of those areas. Support from the ICB has been helpful this year, and they have been really clear that they want to develop a joint plan of work with us and that they want emergency planning leads in each of the provider organisations and the ICB to work more closely together. On economies of scale, but also for the obvious reasons around doing things across organisations. That feels like a step forward and hasn't been the case to date. So next steps, Chair, detailed work plan to meet the areas that we are not as compliant in 24-25, continued focus on the management of industrial action, as we've talked about already today, and again, as other colleagues have mentioned, focus over the next few months on maintaining the urgent and emergency care pathway.
Yeah. Thank you. Are there any questions for John? Thank you. So we know that we're compliant on 52 and partially compliant on the other 6, and also note that we believe we have plans in place to address particularly the industrial action that is proposed. In terms of following up on this, John, is there anything there that we should follow up on through the IPR?
The impact on the UEC and industrial action will be picked up through the IPR anyway. Yeah. Emergency planning specifically reports to the Operational Management Committee, and then a highlight report of that each month comes to the Executive Committee. Lovely. So there'll be a line of sight.
Thank you very much. So we note that. In terms of sealed documents, we note the sealed documents report. Is that correct, David? We note the use of the company seal. Yep.
Yes, Chair.
Thank you. And then in terms of finance and investment, yeah, thank you. And then in terms of finance and investment committee, Nitin, I feel we've given that quite a good airing this afternoon. Was there anything additionally that we needed to flag from the committee?
No, I think we've covered most of the things in the finance report. That's what we discussed at length at the committee. And there were a few points for the private board meeting. So I think we're good.
Okay, thank you. Thank you very much. Are there any questions for the chair of the Finance Investment Committee? Okay, thank you. Quality Committee, Anna.
Thank you, Chair. So, and I think we've also covered quite a lot of ground, and we've got two agenda items. Got complaints, annual report, and medical revalidation annual report to consider. So I just wanted to note very quickly a couple of things. First, it was an unusual meeting because we didn't have the CNO or the CMO with us, but despite that, we worked through the agenda, I think, very successfully. We signed off the PSERF plan, and we're pleased to see positive feedback from the ICB on its comment on its priorities. We reiterated the priority around addressing SI reporting, which Osman has referred to. We challenged the executive on the importance of articulating meaningful outcomes, and we've also been talking about that earlier today. We look forward to seeing the quality dashboard very soon. We know that's work in progress. And I think the other thing, just very, very quickly to note, is I think we've put above the conversation we've already had about outcomes. I think in our discussion, we very much reinforced the need to improve our outcomes on RES and workforce disability. And actually, in addition to improving outcomes, to co-produce the improvement plan that I know is work in progress in order to be as inclusive as possible in getting some improvement there. So I'll stop there, but happy to answer any questions. I know we're short of time.
No. It's fine. Are there any questions for the chair of the Quality Committee? And just to pick up on the point around focusing on outcomes, we are. I think there's a plan to schedule some time at a board strategy session to actually to actually just sort of reboot that and just check we're confident that across our activities we've got the right approach, not just, if you like, to deal with the RES and the WDES, but actually just to think in the rounder sense around actually, are we really closing that equity gap? So that's something we'll pick up early in the new year, I think, following your committee's suggestion. Okay, thank you very much. Can I now move? So I think for today, for me, with the people plan, we just need to note that this is, if you like, a holding position, and that then in the new year we all bring the people strategy. But don't let me stop you introducing the people plan to us.
Thank you, Chair. It was just as I say for noting. So this is the people plan that takes us from October 2023 to April of 2025. And outlines our approach. I don't want to use the term strategy, but our approach to addressing what is our current state issues that we've discussed already on this call around the financial quality pressures and so on and so forth. So it's taking a view of what would we need to do to keep us safe enough, and that's safe enough both from a recruitment, quality, and retention point of view, and really just breaks that direction or ambition into three parts. One is refine, and refine. Two is recruit, and three is retain, unsurprisingly. The refine is really about mopping up all the bits within our progress of work on our systems that just needs to be fixed, and that's why we've called it refine. And so we're saying we need to get this to at least get us in a functional position. And recruits addresses our recruitment challenges, which we cannot look at or consider without thinking about our retention work. So you'll notice our work around EDI, health and well-being, and so on and so forth, sits within within the retention piece of work, and there's a lot of exciting work that we are doing there. But there's, before now, because all the attention has been on recruitment, I think there's been a sense that recruitment was the most important thing. What we're trying to do with this is to say, actually, it's not either or, but it must be taken in a three-part way, which is we have system issues, internal systemic issues, we have issues around recruitment, and then retention. And those three must always be held together as a three-part cord, if you like. And that's how we will then be reporting our work in quarters to take us to 2025. And this will very much feed into our annual planning for next year. And this sentiment is also what will then go into when we think about how we define our strategy for 2025 to 2030. So that's all I just wanted to say on that. It's been circulated through the organization.
Thank you. Are there any questions for the Chief People Officer? Okay, but I think we very much note that this is, if you like, I mean, to say it's a holding position is not quite right, but it's a bridge between where we are now and the new people strategy that I know you'll start developing next year. But it's good to see it captured, and I think it's just good to see that focus on those 3 R's, which is really, really helpful. Thank you. And obviously we'll pick up on that through the reporting, through the IPR, through the rest of this year and through next. So thank you for that for today. Annual complaints, Dan.
This one's been well rehearsed at board, so I had nothing in particular to add, Chair, other than to note my earlier comment about the next phase of our improvement programme.
Yeah. Thank you. I think we have done that. Any questions for the Chief Communications Officer? No, thank you. So I think we note, you know, the really significant improvements in the way that we're processing complaints. I think we're managing to get that cultural shift. As you say, we've rehearsed that at previous board meetings in terms of really trying to make sure we're responding to the issue that the person who's complaining is raising. And we recognize that the challenge, of course, is to then pull out the themes and then drive that through the quality improvement work that we're doing. But I know that will be picked up through the quality improvement plan that will come to us in March. So that's great. Thank you very much. Can I now move to the medical revalidation, which I can't say, but can I move to the medical revalidation and appraisal annual report, please? Chief Medical Officer. That's you, Peter.
Yeah, thank you, Chair. I'm just dealing with muting and whatnot. So the report is there as read. We have had no difficulty with our appraisal processes this year. We've been able to make recommendations for revalidation on time and on target for all, but I think one person who I remember having to have a little help over the line, and you'll be delighted to know that I've just revalidated our medical director for workforce this week.
That
Happy
sounds
to take any questions.
Are there any questions for the Chief Medical Officer? And I'm glad to hear that particular appraisal revalidation went through. Okay, thank you very much. Audit Committee.
Thank you, Chair. I'll take the reports as read and would just draw your attention to the consultant and associate services doctors' job plans. The point there being that we did, internal audit produced a first report, just looking at one particular area. And there were concerns, but in fact, what we've identified is that there is a significant amount of work to be done, and that work is going to move forward. But the review, the audit will be extended to the other areas of the SPFT as well. So at some point, a more detailed report with actions will come back to the board, will come back to the audit committee, and then subsequently to the board.
Okay.
So
thank you very much. Are there any questions for the chair of the audit committee? Okay, thank you very much. So we note that and look forward to seeing that piece of work come back round. In terms of charitable funds, I don't have anything to add to the report as read, other than to thank the team and particularly Colin for the work bringing the strategy of Heads On into alignment with the trust strategy, and to make sure that we're really focusing resource to get the maximum return on investment, and then we're starting to maximize the advantages that having a charity like Heads On in the organization can bring to us. And I think we have made significant strides this year, and really looking forward to the work that's going to take place next year. But I'm happy to take any questions. Okay, so we note that. Is there any other business? Okay, can we stop the live stream, please?